Hello to all of you. We're going to start on this first roundtable about poor quality, non-quality, and irrelevance. We're not going to talk about the observations. We know the situation. There are some concerns. We are here to find solutions and strong, innovative solutions. I'm going to ask the first question to Mrs. Minister to open the debate, how to fight against irrelevance and the gaps with the practice. So we're getting straight to the issue here. It's not irrelevant that the first roundtable after François Cal is on relevance. We have evidently cost reductions in the field of health, and the non-relevance and poor quality is 20% of health spending. It's not specific to France. It's a figure that we find in all OECD countries and WHO. So erratic redundancy of and useless procedures are a source of a cost of reduction in deficits. So how do we do it? So first, we have to be aware regarding health professionals of the cost of non-relevance, of irrelevance. But it's not enough. Today, the methods that we have to tackle irrelevance and poor quality are punitive methods. Health insurance, look at the gaps in practices, is going to sanction professionals, do a number of procedures that are way too high regarding their population that they cater to, and our approach regards the funding method of our health systems, which doesn't assess quality, which is a funding regarding quality, and health insurance is going to look into the gaps in terms of quantity. The other approach, which is necessary, is to improve the whole health procedures, mechanisms, there's more professionals for chronic disease to avoid lack of diagnosis or care. So how do we move to a system that funds mostly quality, and to a system that funds quality and relevance? That's the whole what's at stake here. Today, our issue is that we're not able to assess quality, second, to assess relevance, and to fund correctly, adequately what functions well, and to fund differently what doesn't go as well. So there's a whole change, a shift into practices that go through to a change of funding practices for professionals, which also requires that the quality and relevance is better defined by knowledge authorities, by health authorities, to know exactly what we call regarding what we call quality. We'll get back to that. Mr. DEVULDER, when quality and non-relevance requires an ethical obligation, there's not one doctor that is not concerned about the quality of the cares that he gives to his patients. But, and I think we all do that, and I think we all do it in good faith. But if we don't assess ourselves, if we don't compare, if we don't benchmark, if we're not confronted, it's hard to make progress. And all the foreign examples have shown that to us. And we're late. When you look at what's done in Sweden, the collection of data on quality, it goes back to 1970s. I was 6 years old. I'm no longer 6, as you can see. That's true. And in different systems, when you see what the Dutch have done in the DICA mechanisms, what North America does, I think we have a whole path to cover. And as the Minister, Agnès BUZYN, was saying, I think we know we took the wrong path. I don't think it's the payers' health insurance to be the guarantor of relevance. All the foreign examples have shown that to us. It's the professionals themselves in ties with the patients and different players of the health system that set it up. Finally, in the end, it's our national professional councils or our foreign equivalents that do that. Let me give you one anecdote. I created I'm a gastroenterologist. I agreed with others, the National Council, Professional Council on Gastroenterology a couple of years ago. With Olivier Gaubuissonnière, the professor, I was his representative at the National Federation of Medical Specialists. And the title of this council, at this Congress, I had invited in Paris my foreign counterparts. What was not my surprise when we were shaken by one of my counterparts at university, who's an academic in Amsterdam. What? You do 2 million biopsies in France? What are the results? How many cancers did you avoid? Do people ask you? I think we have to get into this culture, not a punitive culture, but the virtuous circle to get there. I believe we need to start off everywhere where it has been done. The doctors, but it concerns everyone. Patients and all the players into the health systems are compensated for these relevant procedures. If we don't do it, we're going to have facing us, and we can see on imaging, medical imaging, which is in the news today, we're going to have to cut costs everywhere. And I go back on the opening conference, that discussion we had, health that represents 12% of GDP. Tomorrow will represent 4, 15, 18% of GDP. It seems unrealistic and not something we can wish for. We look at who's at the top. We're not the health system that makes everybody dream anymore. Mrs. Minister spoke about the funding, change in the funding. Do you think that medical professionals, those who are ready to accept this funding methods, not by procedure, but covering the path and covering quality, do you think it's an important change in the practices and mentalities? Do you think it's just going to go along well? There's also resistance of professionals. We know that. We're in France. We're Gallic countries. Resistance is strong. I think we should not oppose compensation of the act and relevance. But it's a paradigm shift. To make it simple, payment by procedures is put into question. Ask the Jean-Marc Aubert here in the room, who wrote a wonderful report that he gave to the minister a couple of years ago on the different funding path. And if my memory is good, we don't oppose agility of the payment by procedure and certain decision to payment by pathology, payment by covering different episodes. But I think it's time today to mix these funding mechanisms. Even if we pay by the act, by the procedure, with the word quality, relevance, and responsibility to sum up of everyone. It's not just professionals or doctors, it's also the relevance of people going to find care, the relevance of the functioning of health institutions, public or private. If we don't do that, we're going to be facing cuts that will irritate and will not improve the system. Mr. Collet, we're going to change, we're going to look at the role of the patient. The patient, it's there, but should we reinforce it? Is it one of the means of changing practices? How can we put the patient back in the center of care and quality? I'm going to answer to that, but I'm going to get back to what Mrs. BUZYN and Mr. DEVULDER have said. So the funding methods and the culture. We're in a country that doesn't have the culture of assessment. We don't have the culture. We're in a country which, since middle school, through merit, you might succeed, but we observe it in all fields. We're going to be in the central key field where the recommendations was relevant. How do we act efficiently? The minister, Agnès Buzyn, who was president of the High Health Authority, who knows this topic, and she knows a lot about relevance. When we look today, the issue, what I wonder, who's afraid of relevance? Is it the health professionals that want to remain free of their procedures and we don't look into that? Is it the patients who are afraid because they fear not having all the procedures available to them? And they think it's useful. I hope it's not public authorities. Because they look at costs too. I think there are three keywords we have to keep in mind. First, we know at the High Health Authority, we know how to make recommendations. We know how to define what's the quality of a health path. We have to put this first, being able to oppose. And I don't think it should be so. We have to wonder certain care of the ability to oppose polymedication or autism. 5-10 years ago, we were still into the polymedication. I think it really requires to look into it. So the first is a possibility. So to bounce back on what Franck said, it's tracking. Is really, do we have the power to track medical procedures of each one? I think yes, if we give ourselves the means for prescription. Was it accompanied by software to accompany professionals? Was this software was adequately accredited? We have to go back imperatively in our country to better quality control when there's public funding. The third question is advertising, not in the commercial sense, to make public, so to publicize indicators, whether it's health institutions, where we do on the website of the High Health Authority, but the public should take hand of this data. But we have to go further through health professional, and here we're not into the culture of centered on the health professional. So the patient is at the heart. We have to give the patient has all the demands, and we have to make available these information. If there's no tracking or publicizing, the role of the patient is going to be completely neglected. So we bounce back on tracking, so to publish results. Don't you think that you're going to go against health professionals? We're not going to go back to the whole story. There's been this reluctance to put on the table or into the public results per team, not the whole health institution. Don't you think it's a completely cultural shift to apprehend quality and relevance? This is why I talk about the culture of assessment. We lack of assessment, evaluation culture, and we are facing professionals that have 10 to 12 years of studies, so they should know what's assessment and should be able to hear it. Simply, we still have a lot of paths to cover in that realm. But with the adequate funding method, many health professionals would clearly accept it. Now, I turn, if we need to find new solution regarding AI and digital solutions, how could it help to offer these indicators to ease to facilitate this process? Because you have to prove, it takes time to use these data, are the mechanism to help this change. So first, even if I'm a software editor for hospital, I'm not going to fall into technical solutions cover our the panacea. To measure things, you're going to have tools, and you have to collect indicators and interrogate people, and these tools are more and more transparent, and they should be put into practice with a minimal effort for operators. So whether it's video of operation theater, whether it's reports from meetings where we can measure the efficiency, we could have measures that become simple, easier to implement. But after that said, the tools won't do everything. The tools won't be necessarily accepted in the observation I make, because myself, I use efficiency tools in planification, in surgical planification. We need the acceptance, and we need an implementation that's efficient. And the job today that is lacking in the system, and the one of operations, and the design of these systems, of the quality system, efficient quality systems. In fact, in the observation of the hospitals, or an industrial startup, these jobs lines, these trades, the operational trades in the industry, which are hybrid in terms of skills between the scientific and technical part and the management part, are not clear career paths, and in other countries they're much better recognized. So that's one path we can follow. Before implementing these tools that are developing very fast, we would need the skills to analyze the needs and to deploy them. So to sum up, by changing funding and by informing, we can radically change the culture. Don't you think also there's a groundwork at the level of medical studies upstream to have taught myself, as you did, everything regarding quality? It's not taught. It's not broadly taught. It's marginal. Isn't there groundwork, foundational work to be done, to be carried out before? Isn't there something to be done at the level of universities, academia, to give better space, more space to assessment? Isn't there something to be done? So, yes, on the one hand, there are activities, high-risk activities that cost a lot of money that we've been doing for 20 years, which have been assessed. All the activities that are regulated by the biomedical agency, so infantile protection, we entered tens of indicators in the framework of certification ISO 9000, which is called Classic, which is European certification. The biomedicine agency would gather all the indicators of survival and complications at birth according to the gravity, would rank teams in a slot plot, and we would see were we badly ranked or well ranked, and we could take rectification measures to try to improve when we're not as good. And so this work, this assessment work, creates an emulation which improves quality continuously. And no infantile protection medical team would like to go back. What we managed to do for high-risk activities, how can we not apply it on other activities? Surgery, radiology, we could go progressively. It could be under the consultation, advancing consent of CNP, which requires a collective view to improve practices, a ranking, and a funding according to quality. I think today we need to really trigger the movement. And my idea is not to get rid of the funding per procedure. We have to diversify. We cannot have a medicine that's totally funded according to pay for procedure. And we need to give benefit to those who work well, and all professionals are ready to go in that direction. I'm going to give another remark. So I worked with teams on transplants, but we asked other surgical activities to be assessed. It was impossible. So there's a psychological barrier that needs to be overcome. So regarding patients, because you see that we have surveys, satisfaction survey, which concerns every team, but if we want to go further, so wouldn't there be a means to the feeling of the quality perceived by the patient? There's a gap between what the teams feel. Wouldn't there be a lever to change practices here? We're going to take three simple examples. So the survey after hospitalization, the opinion of the patient about his stay at the hospital. We have all the data, they're accessible, we analyze them. With a tool of AI, a generative AI, we know how to analyze these data, and there's 1,000 health institutions have the tool to analyze their own appreciation of patients when they come out of their hospitals. The real issue that which is not a critical question, how do they use them? How do they reintegrate in their own governance and management these information? That remains to be seen, but it's too recent. We need to give ourselves time. And then the PREMS, I observe that many patients' associations are ready to move forward on this issue, and I see it publicly. We offer at the HAS to elaborate with certain patients' associations. So these mechanisms that would be liberalized by the HAS, but we have to use them. The first step, they would to be validated scientifically. We need to use them, what feedback we get, and how far we use them. Also, in terms of funding. And these are points that need to be put on the table. But I don't represent Patients Association. I see a real interest of Patients Association on this. Mr. DEVULDER, regarding the feedback and the place of patients.
La qualité, c'est quand même
quality,
pour le patient.
It's for the patients.
Les médecins sont là pour soigner les patients. Et
ça, doctors are here to care for patients. We also often forget it.
Si on se lève le matin, c'est pour nos patients. Alors c'est un peu trompé de voir.
If we get up in the mornings for our patients, of course.
On fait pas médecine par hasard.
We don't do medicine by accident. We're not health professionals just by accident.
Ou alors
otherwise, you will have to struggle with many things. But the role and the place of the patient today, which is at the center of the whole health path, was not there before. Before, the speech was, I know what's good for you, and that's it. So it has completely changed. It's necessary. So the PROMS, patient-reported outcomes measures, are get into our culture, and we have to do it voluntarily. We're not so much different from the other. We talk about publicizing, communication, and transparency. Every year, we find a magazine with a red cover that gives ranking on health institutions. And we were first. My hospital in Reims, we were in the first spot many years, so it's good, but I had a bit of competition with journalists. It's not the alpha and the omega of quality. They look into volume and renown. If you're big, and in a department or region, you can have a lot of patients that come. So in Reims, people come from outside departments. We have good quality. People come from all over the place. Or the health university centers. We need transparency. The well is transparency. Look in the UK. In the UK, results of the PROMS are publicized for patients to guide them. Let's do it with methodological, vigorous criteria rather than general rankings. Plus, with other websites that give their own grades. And so let's take this problem in hand and publicize. It's important for patients and health practitioners, health professionals, to be able to compare ourselves to our colleagues. So regarding everything that was said, what could bring, when we go back to the same question, we move forward on indicators, the PROMS and the PREMS, it gives means, database, the biomedicine agencies has the database, and it's true that for many years it's remarkable what has been done there. We haven't applied this method everywhere. I never understood why. Or maybe because there were some professions that didn't want to. That's another issue. It's another debate. So AI and digital solutions would ease these access to information and made available so that health professionals can see their results, own results. So the answer is yes, and it's already taking place. Everything that has been done into the framework of the Ségur to have data on health paths, that it's available on your health space. And so this high, we're on this path. And so the modern computer tools, cloud, etc., everything is going to be structuration of analysis of data. It's there. It's there in other industries, in consumer industry. When you use Google solutions and others, the topic is not the technology. Is technology in real operational conditions and cybersecurity issues, GPRD, etc. And so maybe we kind of use that excuse in order not to move forward faster. So clearly, there's an issue of investment into computer infrastructure and the health systems that we should continue to address. So IT management want to install innovative solutions. They're suffering because they lack skills in budget. And these investments that we will do into infrastructure, into IT infrastructure for health institutions, have a good return on investments because it would allow the deployment of these tools that are really accelerators of productivity. What we could find in SaaS solutions, software as a service, and other open AI, such as the Google Suite. In less than 10 years, you make, like a company like mine, you gained 25% productivity for employees. So that's the opportunity that we haven't seized by modernizing the working tools. So GPRD, hasn't there been blocking an obstacle for health institutions in order to develop these solutions? I think it's an excuse, but there are solutions. We added software. We can deploy local solutions or firewalls. We can extract data if it's necessary. We can also send data in a secure fashion. Technology is there to be able to do that. It has to be done. It has to be addressed with standardized framework. We are seeing. I see the forms that I have to fill out to install in hospitals that become more and more generic and standardized so that we don't multiply administrative burden that will impair their deployment. I share what you say, but first, it's access to data and sharing of data, interoperability. But otherwise, AI, which is in our practice already, but every time I make a prescription, I would like a pop-up that where I would have available recommendation of the High Health Authority and other input to help me. But this problem of data cannot be relevant if everyone is in their own silo, closed off, and locked in. I think people have access to their own health space, but we should work on that. Otherwise, we won't manage to achieve our objectives. And so you talk about all the CNP. Do they have the motivation and the maturity? Guides of good practices. So the High Health Authority, it's their whole. Can they take care of all the recommendations? All the CNPs are important. Do they have the same maturity? And regarding the regulation, do you think it's a future solution? There are CNPs that are well advanced, and others are not up to standard. I'm not sure I'm the best place to answer the question. I'm going to let Lionel Collet, because I left the HAS 9 years ago in the ministry, 5 years ago, so things are constantly shifting and changing, and it's very heterogeneous, but it made progress, I'm sure. I'd like to make a quick remark. We talk a lot about the quality of medical procedures or care or in hospitals or by a professional. I would like to say that in the relevance, there's a whole path element, improvement of the path of the patient's path. It's not just a hospital or a doctor. How do we take charge, how we care for a diabetic or whatever? And I regret Article 51 of the PLFSS, so the funding law for health in 2019, which were well publicized and supported so that we have a shift in the path and other ways to work for professionals, that it leads today so that many experimentations have shown good results, and have proven their efficiencies at regional, local level, and we are unable to deploy it nationally. I think that's a real problem, because we have launched the Article 15 in 2017, so in November 2017, so we're end of 2025, almost, when we know that a path, that it makes us save a lot of money, and it improves the care of the patient, who's better followed with a less erratic path. and we all win. I think it makes me really sad that we haven't set up processes, procedure to deploy it nationally. And that's a source of improvement for quality that lays on proven data. I think Lionel is the guarantor of science, and that's my struggle. This needs scientific rationality to show that to prove that what we do is efficient. So Article 51, it proves we can show efficiencies on the CNP. Do you go on the CNPs? Okay. So first, I would like to remind you that there's an ordinance, the ordinance of the periodic certification of health professionals that was following the health law of Mrs. Agnès BUZYN when she was minister. And what's interesting is this ordinance that the referentials, the frameworks for each professions are elaborated by the CNPs. So a fundamental mission was given to the CNP to have referentials set up so that professionals, to determine if professionals are certified. So we intervene. Only the HAS upstream, it elaborates, it did it quickly. The methodology to elaborate these referentials, and the minister can, before making the decision, they can decide maybe the HAS should look into that. So we wish, so they're mostly of good quality. So are all the CNP equal? That's a trick question. I'm not going to answer like this. There's a history of the CNP, of medical professions. Pharmaceutical are old, and they're used to work together, the knowledge societies and councils. Some are less old, and thanks to this ordinance, have become better structured really fast in terms of quality requirements. And so, is the CNP the good counterpart, partner? Yes, I think if we have to develop here at the HAS, what I've developed, labelization of recommendations elaborated by the CNP. So going back to Franck, there are recommendations by the CNP and the HAS, yes. When the HAS redacts its recommendation, it's experts. Experts are in knowledge societies, and they are also present at the CNP. They are not to be opposed. Yet, with the points of difference, which is not so much divergent, but they could become divergent, the fundamental difference in the recommendation of a CNP or knowledge authority and recommendations of the HAS is the methodology and the independence of those who have contributed to these recommendations. When we develop labelization accreditation methods, the methodology that we expect, who accompanies them, the job is done clearly, but the whole issue of the declaration of conflicts of interest of the people who have contributed. And so CNPs are our counterparts, are privileged for us, privileged counterparts. So I think that the stone, the cornerstone, is the independence of contributors and lack of conflict of interest. Professionals, health professionals, in ties with the patients, always in dialogue with the patients. The whole system has to shift. I think relevance is at the heart of our reflection. Our health system, we saw in the previous conference, is submitted to, I think, in my view, two major challenges: financial sustainability. How do we fund a health system tomorrow that will celebrate its 80 years, and how we approach the next 80 years? I heard the figures today. It's 22 billion deficit into the so there's 10 of stock effect of the CGRs of the last reform. So, but still, and the second challenge is access to care, and in the access to care, that's the relevance, is the first relevance, first quality, is to find the right doctor at the right moment, with territorial responsibility, according to the populations, and all this is part of what we together have to put in place, and what we have to put on the table together, and the paths are there. It's not easy for a president of the CSMF, because some unions have defended the only payment by procedure, but particularly for chronic pathologies, and not just for the first resort, that payment per procedure, but the lump sum payment could be applied for other health approaches. So if I have a Crohn's disease patient and I see less and less my patient because it's a good thing with therapeutic improvement they do better, but my obligations also have changed in my practices. I only have one thing. I want to work with other health institutions, the pharmacists, nurses, and I need that. But if it's just payment per procedure, procedure is important, but we need this cultural evolution. Before concluding, regarding the Article 51, I think the path is a fundamental issue because there was breakdowns in care. How do we do to improve? So there's been different experiments after Article 51. How do we do to improve this relation between city hospital? I practice in hospitals. There's a breakdown, maybe improved a little. We have solutions, not miracle solutions. You mentioned Article 51 and experimentation of Article 51, but aren't there other solutions? I'm going to be a bit disruptive here, but we have to. The conventional framework, as it exists today, in silo between professionals, in silo between liberal practice and hospitals and Federation of Houses impacts negatively this improvement that we wish about this ties between city and hospital and professionality within health path. I think the conventional framework has to change. There has to be a part of the conventional framework that puts together all players and that brings funding and compensation of different nature. As long as we have this negotiation completely separate profession by profession, we won't manage to transform the system. There's no incentive, no possibility to the health funding fund. And I'm going to publish a book shortly to how to modify the conventional framework, how to bring in the conventional framework finding ability regarding employee professionality, funding, also a lump sum approach, and to rethink diversification of the competition mode of the whole system, not just liberal medicine, but also hospitals. To conclude, so to bounce back what Mrs. BUZYN says, 2008 or 2009, I remember, the High Health Authority came up with a text to say that development of quality would go along with development of cooperation between health professionals. This is 2008-9. So what I just said goes in that same direction. It's cooperation. And what's at stake in this roundtable? How do we act on behaviors? We have to act through behaviors through the funding method and through cooperation. Monsieur DEVULDER, I completely agree. Mr. Agnès BUZYN, the necessary reflection we should have on the evolution of conventional framework in structures or health offices where we gather 11 professions. I really believe that the convention is a plus because it gives a refinement, granularity, but the first goes back to 1970. It's very, very complex. We had a medical convention that was 40 pages. Today, we're going to make it simple. It's 800 pages. It's not read, not applicable, and not enforceable. So doctors and funding of health institutions should have funding that evolve every month of March, and other professions every 5 years. We're all in the same ship. And allow me to say one word on the work. And so there's very good things. And it's not just hospitals. We have to do that together. Health needs a programmatic law, and we don't have it. Just to finish off, so 9 seconds. Evidently, investments are going to make things happen, and that allow us to acquire the tools, skills, but maybe the patient with ChatGPT is also going to challenge the system of relevance of his own care and force. Thanks to all of you. We have made interesting proposals now. Now deciders will use them. Thanks to you all.